Hello, everyone. Hope you guys are having a good day. I've been quite busy with other things, but as promised, I'm trying to. I did my best. I put my best efforts to get this PowerPoint ready in time so that it's available. And I actually realized while making this PowerPoint, there are a few points which I tend to forget, and it was sort of like an eye opener for me as well. And Again, when you compare with the old therapeutic guidelines, there are a few changes with the pain management. So I think it's of great value in having this PowerPoint for you guys. So today's topic, pain and pain management in dentistry. Uh, the reference for this PowerPoint is exclusively therapeutic guidelines and nothing else. I think that's more than enough for general dentistry. So let's start. Now, before we go into the medications required in the dental area, we need to understand the concept of pain. So, what's pain about, and how is the pain of odontogenic origin going to impact the patient, and at the same time, how are we managing it? Generally speaking, odontogenic pain a is a type of nociceptive and inflammatory pain. It usually arises because of some damages happening to the dental pulp or the periodontal tissues. Now, the different odontogenic origin, it comes from usually from pulpal abscess, and the treatment is should be on dental purpose. Okay, so let's say there is a tooth which has got some inflammation or causing some inflammation in the pulp, then or an abscess, then we have to consider that to be an odontogenic origin. And in such situation, what the therapeutic guidelines say is just by giving a painkiller is not enough. You have to provide some kind of adjunct dental treatment. Now, there are certain inflammatory mediators which sort of are involved in this thing. There are prostaglandins, there are bradykinins, and histamine sensitize the nerve endings. Now, how are we assessing? We are doing through a general clinical examination, followed by some periapical radiographs or OPG, depending on the need. Now, the causative organs, I mean, which nerves are predominantly involved here? So there are two types of nerve fibers. One is A delta and then the C fibers. So these two are the ones which you need to remember. Okay. Now ignore the conduction speed, but I would focus more on the sensation. So whenever there is a sharp piercing or shooting pain, that's because of stimulation of the A delta fibers. Now with the C fibers, the the type of pain is dull, aching, or throbbing, and poorly localized. So all these dull, throbbing, poorly localized is from C fibers, and sharp piercing and shooting pain is from the A delta fibers. Now, if you read endodontics, uh, you know that the sharp piercing shooting pain is usually stimulated because of certain triggers like cold, heat, sweet, or sometimes air. Whereas the dull throbbing ache, these are because of inflammatory mediators which are acting on the damaged tissue. Now, clinical sign of A delta fibers, it's usually reversible pulpitis. The pain origin because of reversible pulpitis is because of the A delta fibers, and irreversible pulpitis or necrosis pain is because of C fibers. So if you gone through the endodontics properly and based on the origin of pain, we should be able to identify which one is from A delta and C fibers. Now, when a patient's having pain or is in pain, what instances are we referring them to a specialist or emergency? First one, airway risk. So when a patient attends your clinic and he or she is having difficulty in swallowing, speaking, breathing, and you notice that intraorally the tongue looks like it's elevated, then that's a risk of airway compromise. So you have to refer them urgently. When there is severe swelling and then there is a trismus where there is restricted mouth opening or on top of neck swelling and periorbital involvement, then you have to refer them as well. Then systemic features, patient's got temperature of more than 38 degrees centigrade, having malaise, tachycardia, and signs of sepsis, you just refer them. And last but not the least, you can see the patients having atypical facial pain, which is not of dental origin, something like trigeminal neuralgia, or a patient feels sudden numbness, that should be referred as well. Now, just an overview of reversible and irreversible pulpitis because we are discussing pain. Just go through this. I'll probably not spend too much time on this one, but thought it would be interesting to have this table here. Now let's look into this. There is something called as antibiotic stewardship, which basically talks about antibiotics. Um, what it says is antibiotics are only prescribed if procedure is delayed for more than 24 hours or systemic signs develop. So your first choice, a patient comes with dental pain, your first choice is not antibiotics. As I mentioned earlier, you have to perform dental treatment, and if required, you can give painkillers as an adjunct, but not antibiotics. It's not required straight away all the time. Okay. Now, if there is cellulitis, like a spreading odontogenic infection, and especially when you see swelling extending beyond a certain area, you need to do the immediate dental intervention and antibiotics. Okay, the recommended antibiotics are amoxicillin, metronidazole. Again, we are not discussing antibiotics here, so I will not go in too much depth about antibiotics. Now, the rule of thumb is antibiotics are not painkillers. They do not relieve pain in irreversible pulpitis. As I mentioned earlier, you have to do appropriate dental treatment. Now, certain considerations you have to look into, such as alveolar osteitis, or commonly called as dry socket. The most common reason is premature blood clot lysis. So usually pain occurs 1 to 4 days post operation or post extraction, and the pain is severe. And the management is initial management goes with you got to do a warm saline flush and give an abundant dressing such as alveolar gel, and antibiotics is of no value for alveolar osteitis. Next one is temporomandibular joint issues, where there is pain in the TMJ. The management is again rest, soft diet, warm compresses, and a short course of NSAIDs like ibuprofen 400 milligrams. Then we look into necrotizing gingivitis. Clinical features, you guys know about it. The most common management is again here you have to give antibiotics, metronidazole, and then chlorhexidine mouthwash and urgent debridement. So these patients have severe pain. Non-pharmacological adjuncts in local anesthesia. So this has been clearly mentioned in the therapeutic guidelines. So I just thought I'll create an individual slide for this one. So what it says is using local anesthetics is a method of pain relief. That's interesting. So you can use long-acting anesthetics like bupivacaine or marcaine, which provides pulpal anesthesia for 1 to 3 hours, and soft tissue anesthesia for 4 to 9 hours, easing the transition of oral analgesics. So while then you think that the anesthesia will be wearing off, you can give oral analgesics. And it also says, basically, therapeutic guidelines also say that mandibular blocks offer long-lasting relief of pain for lower teeth extractions. So instruct the patients to take the first dose of oral NSAIDs or paracetamol as per required before the local anesthesia wears off. So this is an interesting strategy you have to remember. So combining NSAIDs and paracetamol provides superior pain relief to either drug alone or opioid paracetamol combinations. So as we keep going, we'll discuss what type of medications are we giving, but generally speaking, there is a combination of an analgesia regime as well, where NSAIDs block the peripheral prostaglandin synthesis, like COX inhibition, and the paracetamol works central on the central nervous system, and it elevates the pain threshold. So you know that paracetamol acts on the central nervous system, and NSAIDs act on the peripheral. Dosing strategy, yeah, you just go with the regular dosing as per normal, but there is an order of giving these medications and altering them, and then there is an order of stopping um, NSAIDs first and then the paracetamol later. So depending on the patient's needs, that also we'll cover as we keep going. So NSAIDs are the gold standards for dental pain management because NSAIDs are good, strong inflammatory agents. So most of our dental origin pain is because of inflammation. Okay? Now, COX-1 drugs, they maintain gastric mucosa, renal blood flow, platelet aggregation. So non-selective NSAIDs like ibuprofen block this, causing gastrointestinal upset and bleeding risk. So COX-2 are produced during inflammation or trauma and sensitizes the pain receptors. So here they're both non-selective, and COX-2 selective Celecoxib block this pathway and give pain relief. So here the clinical choice is you got to use ibuprofen first as a first line. Only use Celecoxib if the patient has gastrointestinal issues, ulcers. But if a patient's got severe cardiovascular diseases, please avoid. Now let's look into the pain management in an adult. So when a patient's got mild to moderate pain, okay, just remember one thing: always use a two-drug regime when there is a mild to moderate pain, and you cannot go beyond 5 days without further review. So drug of choice first is Celecoxib, 100 milligrams given orally, and you can give them 12 hourly for the shortest duration as possible, less than 5 days, as mentioned. The second one is a combination of ibuprofen and paracetamol. Now, ibuprofen is normal dosage is 400 milligrams. We can give it 6 to 8 hourly, and that's a maximum dose of 1200 to 2400 milligrams. That means 3 ibuprofen to 3 to 6 tablets of ibuprofen. That's a max. And then paracetamol is altered. So paracetamol, 1000 milligrams, which is generally we get 500 milligrams one. So two 500 milligrams orally, 4 to 6 hours. And please restrict the paracetamol usage to maximum of 4 grams for 24 hours because paracetamol causes liver toxicity. And it might be asked because there are a few heavy paracetamol poisoning cases which been reported recently, and it's actually been in the news as well. They were trying to regulate the paracetamol. I think they want to decrease the number of paracetamol tablet on a strip. So we'll see what happens. Anyway, if NSAIDs are contraindicated, then you just got to stick with paracetamol. Again, the same max dose of 4 grams. So this is a screenshot from the therapeutic guidelines. You can pause it and go through it at your convenience. Now this three-drug regime, as explained earlier, when NSAIDs plus paracetamol are genuinely not enough in cases such as surgical impactions or irreversible pulpitis where the patient is waiting for root canal treatment, you can add an opioid analgesic, which is Oxycodone 5 milligrams or tramadol 50 milligrams, 4 to 6 hourly. Okay, and these ones you have to restrict to a max of 3 days, right? And avoid codeine. That's been taken off from TG. Previously, paracetamol and codeine combinations and those were recommended, but now they say that no, just avoid codeine. Now there is something about opioid stewardship which you have to know. So traditionally, dentists were the high top prescribers of opioids. Now, because there were a few other issues, that's why the opioids have been restricted for various reasons. Even if prescribed, they say don't prescribe in a full box. You have to give a limited prescription of about 6 to 10 tabs only, and always warn the patients about the possible side effects such as nausea, constipation, dizziness, uh, dependency as well. If in case a patient did not complete his medication of opioids, then you have to instruct the patient to return the unused opioids to a pharmacy and not just hold on to them. Sorry about this slide. It's quite messy, and I didn't put much attention to fix it because it's not much in there. So basically, what therapeutic guidelines was saying is there was an alternative opioid option for severe dental pain. They did specifically mention about tapentadol, but again, they did mention that dentists will not be giving this drug. So just for your understanding, just remember the name, but it's not to be used by dentists. So So ignore this if this drug comes up as an option. I thought I'll give you guys a heads up. So you can see below, I did mention that medical practitioners, oral medicine specialists, or hospital-based dental practitioners, they are the only ones who can advise this drug. Coming to the NSAID risks, gastrointestinal toxicity, cardiovascular issues, asthma, and renal. So when we so do not give aspirin in patients who got peptic ulcers because it might induce gastrointestinal bleeding. A patient who has got severe heart failure, please do not advise that, and uncontrolled hypertension as well. Okay. Asthma, should be avoiding it. Caution with aspirin, especially as there is NSAID induced asthma, followed by patients who got severe renal impairment. Please avoid NSAIDs as they reduce renal blood flow. And also do not use aspirin in children who are less than 16 years of age because of the risk of Reyes syndrome. So what you see in Reyes syndrome is basically a fatal liver condition, and there is brain swelling happening. Few other considerations. So pregnant women, you got to prefer using paracetamol, and NSAIDs must be avoided, especially in the third trimester due to the premature closure of ductus arteriosus. And in the elderly, we discussed again previously the gastrointestinal bleeding and renal impairment. These are quite common in the elderly individuals, so we got to be mindful. Even if you're using NSAIDs, you have to use lower doses and stick to short duration. Also, it's important to consider the other medications they're using sometimes, because these are some of the analgesics. They might interact with warfarins or serostonic uptake inhibitors. So just be mindful of when you're when you're giving NSAIDs to elderly individuals. Hepatic impairment. So as I mentioned earlier, liver toxicity is of concern, especially when patients use more paracetamol tablets than required. So also be mindful in patients who got severe liver disease, chronic alcoholism, and always reduce the paracetamol max dose as well to 2 grams per 24 hours, or just avoid it if possible. Now coming down to the dosage, in children and adolescents, therapeutic guidelines did emphasize that always dose by weight, not age. And in kids, syrups are preferred. So ibuprofen dose over 3 months. You can use it uh, in patients who are over 3 months. Okay, and other than that, also who are 3 months. Let's say someone is 3 months, and also the weight should be over 5 kilograms. If it's less than 5 kilograms, you're not using it. So the dosage is 5 to 10 milligrams per kg body weight. Right? And then the paracetamol, 15 milligrams per kg body weight. Now, there's been a mentioning about calculating dosage in children who are obese. Is you don't calculate based on their weight. If you see a kid who is obese, you got to calculate the dosage based on their ideal body weight for that age. So basically, that's what I told you guys. It's a repetition of the same thing. So this is a screenshot from the therapeutic guidelines for your reference. Now, this sort of finishes the pain management. It's simple, straightforward. All you got to remember is moderate or severe pain, what painkillers are you giving? Now, it gets complex when you're thinking more like if it's an adult, there's a certain dosage. If it's a child, there's a certain dosage. And if it's an adult with certain medical conditions, then your choice of painkillers varies as well. So I want you guys to actually go through this one more time, and at the same time, uh, the best way to for you guys to memorize is after going through this video, I would suggest you to just close your eyes, grab a pen and paper, and write down the pain management just to break it down for adults and children. Keep it simple first, and then you can think about the variances. Okay. Now, as usual, I have sort of created some MCQs for you to assess yourself. I'll be playing it maybe 10 seconds a slide. If you want to slow down, you can pause the video and assess yourself. All the best, and I'll see you next time. But have a look at this quiz before you stop playing. Thank you for that. That finishes the PowerPoint, and please like and share this video. I think as per the YouTube algorithm, it sort of shows up or pops up on your feed whenever I post a video. I think it'll be of great value for me as well if you share with everyone, and I wish everyone gets benefited because of the content I'm creating. Thank you very much. See you next time.